Good afternoon, everyone. I'm Josh Benner. I'm the president and founder of RxAnti and a visiting scholar at the Brookings Institution. And I want to thank the staff of AJMC for the invitation to come back for the second year in a row at this conference. I really felt like this is an important community that you all have convened to focus on this public health challenge. And it's our pleasure to be not just a participant this year, but also a co-sponsor. So for those of you that might not know RxAnti, we're a healthcare improvement company. My own background is that I'm a pharmacist and a health services researcher and now an entrepreneur. And we're motivated in particular about the problem of improving medication use in the population. And our products and programs are distinguished by the use of advanced analytics, predictive analytics, decision analytics, that can be used to personalize the process of population health improvement. And so what I'm going to describe for you today is the construction and the results of version 1.0 of a new program that we developed last year focused on doing just that, improving medication adherence in this case, through better engagement of healthcare providers in the field, but across a whole population of several 100,000 Medicare patients. So I'm not going to offer any slides today on the problem of non-adherence to prescription drugs. I'm afraid that you all have probably been tapped out on that topic in the past and are well aware of the challenges. But what I do want to show you is one quick slide on why this is a problem worth investing in. If you look at what America spends on prescription drugs every year, does anybody know what the number is? What do we spend on prescription drugs in this country? No volunteers? No IMS employees here? It's about $325 billion last year. Guess how much we spend to clean up the consequences of misusing those $320 billion worth of prescription drugs? Jan Berger. It's about $300 billion. So for every dollar we spend on prescription drugs in this country, we spend another dollar trying to fix the consequences of their misuse. And that's why the best research on this topic shows over and over again that whether you compare it to the cost of coronary heart disease, diabetes, cancer, preventable readmissions, pick the healthcare population health improvement topic du jour, this is bigger. And unless we get our arms around how our population uses prescription drugs, we can't actually get at the root cause of many of these other conditions. And diabetes is no different. So that's why we're motivated to try and attack this problem from the ground up. And I'm going to share our experience today, which is grounded in a payer-sponsored, provider-delivered context. So I have to explain just a bit of context around the Medicare Advantage program, because that's the fishbowl in which we deployed this program. So Medicare Advantage is how many of you work for payers? A health plan? Ed, you're the only one. How many of you are providers, work for some sort of healthcare delivery organization? Okay, several. And the rest of you, I take it, are healthcare executives, pharma, or those kinds of organizations? What am I missing? Patients? Good. So some of you may not be familiar with what Medicare Advantage is in detail. So I'm not going to go, I'm going to do one slide on it, maybe two. But it's important context. If you turn 65, you have the opportunity to enroll in Medicare. And Medicare sort of comes in roughly two flavors. The fee-for-service Medicare, where you present your card at the doctor's office and the doctor gets paid by Medicare for the services that you consume. And you pay a premium every year, and that's how fee-for-service Medicare works. Let's call that traditional Medicare. Medicare Advantage is an innovation that came along a little more than a decade now to try to use private sector incentives to contain the cost of caring for America's seniors. And basically, this has been known as Medicare Plus Choice or HMO Medicare, but basically, you pay a premium to a Medicare Advantage plan, which is operated by a private sector health plan, Humana, United, Aetna, And those plans also get a premium from the federal government for your care. And they manage it, just like you're a member of an employer-sponsored health plan or any other health plan setting. Medicare, as a federal program, tries to manage the quality of care in the Medicare Advantage program through something called the star ratings. And the star ratings is sort of like the restaurant guide for selecting your Medicare Advantage plan. A 5-star plan is the highest possible performing plan on 58 or so quality measures. A 1-star plan would be a very low performing plan. And so the goal is to get all of us, when we turn 65, to select the high performing plans by giving star ratings based on the quality of care delivered in those plans. Okay. In Medicare, star ratings, medication adherence turns out to be a pivotal part of how to get to be 5-star or 4-star. In fact, let me quickly say what's on the table here. If you are a 4-star plan or above, you get big bonus payments from Medicare to recognize your achievement each year. If you have less than 4 stars in your overall star rating, you don't get bonus payments. And these bonus payments are substantial, and they drive health plans' investment in care management programs. Right now, about 38% of Medicare Advantage plans are 4-star or above, and 62% have less than 4-star overall rating. But here's the fascinating thing. Medication adherence is 3 of the 58 measures in the program. But those 3 measures are disproportionately vital to achieving 4-star status. They are heavily weighted in the scoring of these measures. If you look at the contracts that are 4-star or above overall, all of them have at least 3-star ratings on those medication adherence measures, and diabetes is one of the 3. None of the 4-star plans had less than 3-star averages in their adherence ratings. So adherence, just like it's key to preventing readmissions or containing the cost of heart disease, it's key to being a 5-star Medicare Advantage plan. So the reason I've spent 5 minutes on this slide is because now you understand why payers who operate Medicare Advantage plans want to improve adherence among the beneficiaries of those plans in the Medicare population. And so our company has set out to help those plans do that as efficiently as possible. And by the way, before I leave the policy introduction to this topic, these incentives are working. If you sit at Medicare today, you are high-fiving your colleagues over the impact this has had on medication adherence. Look at the national rates of adherence to the 3 categories of drugs that are included in the star ratings program. This policy, where we pay bonuses for this, was introduced in the 4th quarter of 2011. I showed this slide last year, but we didn't have these additional years of data yet. But now we do. So in 2010, before we had it, the national adherence rate for oral anti-diabetic drugs, this is your diabetes oral meds, is the green line here, was 73%. For the RASA category, the renin-angiotensin system antagonists of antihypertensives, it was 72%, and for statins, it was 68%. Look where it is at the end of 2013. And look how fast that ramp up has been after this incentive was introduced in 2011. This is why Medicare has just in the past week said, these incentives are here to stay. We are not removing these incentives. We are keeping our foot on the gas. And this is why it's so important for plans to figure out how to keep pace with this rate of improvement in order to keep their star ratings up. All right, so if you're a plan and you're trying to improve, you need help because you got hundreds of thousands of lives to look after, and changing people's behavior is very difficult. And so we developed a program that we thought would help those plans improve with 3 components. The first component was using predictive analytics to target individuals effectively. And we have a motto that is, if you know the future, you can change the future. And our goal here has been to flag the members that are at risk of stopping their medicines before they actually do. And secondly, when you roll members up into groups, look at the forecasted level of adherence in order to figure out which populations need investment, greater investment in adherence than others. The second step was to help the plans target their plan-to-member outreach. So these are phone calls or nurse case managers where the phone call comes on behalf of the health plan, in order to help make sure you understand the need for therapy and to offer practical aids to better adherence, for example, home delivery through mail order pharmacy. And then the third component of the program, which is the one I actually will spend the rest of my time on today, is to equip providers, people's own doctors and their own pharmacists, to help those patients manage their medication use more effectively. And our goal with this new component last year was to build the nuclear bomb for medication adherence. Those other interventions I described have some effect, but it's pretty limited. And if you read the science, the 40,000 articles that have been published on medication adherence, you're going to see consistently that there's nothing more effective than getting people's own doctors, own pharmacists, own nurses, the people they trust for healthcare information, to help them manage their medication use better. The problem is there are all kinds of barriers to doing that over scale, whether it's multiple states, hundreds of thousands of lives, thousands of providers. It's just damn hard. And that's why the literature's full of little case studies of a few doctors or a few pharmacies who succeed at this, and a lot of failures when we've tried to do it at population scale. And so we set out to see if we could beat that track record. Frankly, it's a pretty low bar. So if you're interested in doing work like this, I have to recommend two recent papers that, to us, were really consistent with the approach we took. And since I won't have time to describe everything about the approach we took, I'm going to refer you to the same two papers that contain a lot of this information. These are papers that focused on equipping providers to manage people's medication use better. The first one was published in JAMA last January 2013 by Ashish Jha, the Harvard health economist at the School of Public Health, who talked about how if we're really serious about engaging providers and improving population health, we've got to get serious in a totally new way about pay for performance. The second paper was in the New England Journal of Medicine. It was by Lisa Rosenbaum and Will Schrank, on Taking Our Medicine, Improving Adherence in the Accountability Era. Again, a similar theme, but less about pay for performance and more about the practical tools physician practices need if they're going to be accountable for people's medication-taking behaviors. If you read both of these papers, you're going to come away with sort of three key ingredients in any program to try and improve. The first ingredient is it has to be their job. These providers today have economic and workflow barriers. They are focused on a lot of stuff besides whether the patient takes the medicine once they leave the office. And making it their job is the first step, and that means paying them. The second component has to be keeping the list of patients who need this focused. I'll show you some examples in a few minutes, but the history of P4P programs has often been sending doctors complete census lists of all their patients and how non-adherent they were last year, and saying, if you can get these patients back next year, that'd be great. And what does the doctor do with that? Nothing. It's not an actionable list of prioritized patients at risk, people you can do good for right away. So careful procurement of the patients, and therefore then the doctors and pharmacists and nurses, is an important second ingredient. The third ingredient they talk about in this paper, or both of these papers, is we have to give these providers the tools to win. We can't just make it their job, give them a list of patients and say, good luck. They need tools to know how these patients are using their medicines and how to manage that more effectively. So we tried to include all three of those ingredients in the program that I'm about to describe. So first, I'm going to just give you a couple of screenshots of the tools that the health plan used to allocate resources across this big population of several 100,000 members. So the first question is, which groups of this population need the investment in better adherence? And so this is something we call RX forecast. The name of it's not important. The idea is we're forecasting the adherence rate to diabetes medicines across 1, 2, 3, 4, 5, 6 different cohorts of this population. These are defined regionally, geographically. So this might be the state of Kansas, this might be the state of Louisiana for this big national health plan. And what you can see is if we know with the little horizontal line in the middle of the black stripe where they're likely to end the year with their adherence rate, the plan can say, Well, this contract over here, see, that's above the 5-star threshold, so that's a 5-star adherence rate. They're happy with that. Adherence rate there is very high. This plan over here, this contract has a 1-star adherence rate right now. That's why it's red. So they might want to invest a lot more in trying to drive the rate up in that population, and if they weren't happy with 4-star, they might want to drive the rate higher than that in this population, and so on and so forth. So the first thing we did was forecast where subgroups of the population would be so that resources could go where they're needed most and could do the most good. The second use of these analytics, though, is to identify the individuals, the members of the health plan who are at risk of stopping their medicines too soon, and which of those patients are most likely to respond to each of the interventions the plan can deliver. So what I'm showing here is the probability of a patient being adherent. Now, what does adherent mean in the Medicare program? It means they have a proportion of days covered, PDC, better than 80% for the calendar year. So this is the old 80% or better threshold, and it's based on filled prescription data. So if you fill enough prescriptions to have 80% of the days in the year covered by that medicine, you're adherent. So what we're showing here is the probability, that is 1% up to 100%, of each patient being adherent in this plan as of last July. So this is the distribution of that probability, and what you can see quickly if you look at that is that a lot of these people have a high probability of being adherent by July. They look like they are probably in pretty good shape. There's a big spike of people who we're pretty confident are not going to be adherent by the end of the year, and we call these people in the middle the undecided voters. They're still uncertain about whether they're going to be adherent or not by the end of the year. For each intervention, we go back and ask, which of these patients are most likely to benefit from that intervention? And for this one particular intervention that I'm showing here, which happens to be interactive voice response telephone calls, robocalls from the health plan, the sweet spot, or the most effective people, are people with scores from, or probabilities from 40 to 80. So the undecided voters happen to be the ones who benefit most from that kind of intervention. But we do this for all the interventions so that we understand their sweet spot and can give the intervention to the patients for whom it's likely to do the most good. And this takes interventions to very different populations than they may have gone in the past. So a common way that plans had deployed these interventions before they could know the future would be to pick people who were non-adherent previously. And so what I've done now is I've highlighted the members of this Medicare plan who were late to fill their prescription for their diabetes medicine at the time we created this chart in July. So that's a simple business rule. 14 or more days overdue to pick up a refill would pick up all the patients that are colored blue here. That was the way this plan was targeting this particular intervention, the robocalling intervention. The median score for the blue people is 8. And you can see that this intervention was being given largely to people where it's not effective at all. And we were missing a big opportunity to give it to people where it would work best. So by correcting who gets each intervention, it made a big difference for the plan in their own member-specific outreach. But now let's talk about engaging the providers directly, because that was the third component of the program that I really want to spend the rest of our time on. So those of you who are physicians won't be surprised to hear this, but I thought we were going to go out and say to these practices, great news. We are going to help you manage medication adherence among your patients, and they were going to hug us and tell us that was their highest priority and that they would jump right on that problem. Guess what? Not so much. These practices are dealing with a lot right now. You just have to read today's Wall Street Journal or New York Times. These guys are getting hammered. These practices are in a battle for survival right now. They're getting hammered by the need to adopt EMRs, electronic medical records, to satisfy meaningful use criteria. They have to incorporate a whole new system of diagnosis coding, ICD-10. They have to worry about whether Medicare is going to keep paying them next year what they got paid previously. That's the sustainable growth rate, for the doc fix that we've been reading about in the paper. Their practices are being bought and sold and consolidated. Hospitals are out on the prowl. Health plans are trying to buy them. And now they're also suddenly accountable for all these cost of care and quality measures, most of which are not medication adherence, by the way. And so it's rough being a physician practice these days. And if you want to approach a physician practice in this milieu, you got to be pretty sensitive to what's going on with them. And when you say, I've got a pay-for-performance program for you, the next thing you hear is their top 10 list of things that they hate about P4P programs. And I don't blame them. They get long lists of too many patients. They get windfall payments on patients that they didn't do anything for, and they don't get paid for patients that they're just busting their rear ends for. They have too many measures to try and keep track of. They're not getting paid enough to do it. They don't have incentives that are linked to the outcome they can create. They're getting paid to fill out forms and document attempts at improving patients' health. They don't get paid on time, so incurring the investment in doing this has nothing to do with when they actually get paid, so economically it's not viable. They're getting sent old data to base all these decisions on from last year, which doesn't help them at all. They're getting sent wrong data on a lot of their patients, or the patients that aren't actually theirs get misattributed to them. They get no feedback on how they're doing, and most of all, they don't get told how to win. There's no clear implication on how to get the bonus that might be available in most P4P programs. And what we heard consistently when we started talking to practices was, just tell me what to do and who to do it for and what it's going to mean to me on the back end, and I'm in. And so I got to say one more thing about P4P historically, which is that it can also be a big waste for payers. We've looked at several P4P programs that payers have tried over the past few years to improve medication adherence, and this is an example of one, but it's a representative example. Remember, this is the probability of people being adherent on their own. This is the percentage of members, and when we look at who was in, this is a particular P4P program that one of our new customers had run the year before, 73% of the people they picked for this program were already 80% or more likely to end the year adherent on their own. So the payer was going to pay out bonus payments on patients who didn't need it. It was the wrong patients were being subjected to this incentive. So what we set out to do, of course, was to fix this 10-item problem list with targeted patient lists that were very short for each practice, focused on the patients not who were lost causes and not who were doing just fine, but who were at risk of having something bad happen over the next 4 to 6 months. That risk-based targeting was also focused around a few measures: adherence to 3 categories of drugs, diabetes and cardiovascular conditions that the physicians understand the importance of adherence to. Because it was a short list of patients, we could give them a large bonus payment for each of those cases if they were successful in improving their medication use, as opposed to a small one. And we linked that incentive specifically to the outcome. So this was gain sharing. This was, you win a big multiple hundreds of dollars bonus per patient that you make adherent to these medicines, and you get it by the end of the year when the outcome is observed. And we gave them real-time data to monitor and manage these patients with through a web portal that I'll show you in just a moment. We also gave them an opportunity to raise their hand if they saw a patient in their list and say, that's not my patient, or that patient is deceased, or I took that patient off that medicine, stop harassing me about their medication adherence. It was clinically inappropriate for them to be on that medication. And so when they could send that information back, they felt much better about the list they were looking at, knowing that it was a list of clinically indicated adherence cases. And then finally, we gave them benchmarking and progress reports and clearly articulated enabled actions. So we said, there's a literature of 40,000 articles on this topic. If you do these 3 things, you will change these patients' behavior. And those 3 things were a motivational interview, enrolling them in home delivery of their medicines where the cost is lowest and the access problems are avoided. And the third thing was bring them in for a cadence of visits and labs that are going to create a sense of self-efficacy. Let them see how well, from their cholesterol numbers, their blood pressure numbers, their A1C numbers, let them see how well these medications are working. Simple stuff that the literature has published the value of over and over, but which we just don't do in practice. This is a quick look at what the tool looked like that we used. It was a training-free 4-page website, a home page that gave them a sense of what was on the table and how to win it. It was very intuitive, interactive design. A patient list was the second page, And each patient, so this is one row per patient, one box for each of the meds they're managing, and a reminder of the bonus opportunity if they could get these patients to take their medicines appropriately between now and the end of the year. These were all at-risk patients. So the goal was to manage every one of these patients on this short list we gave each practice. And what you were managing to, if you were one of these practices, was the number of untreated days in the calendar quarter, which is a pretty simple thing for a clinician to think about. If they don't have medicine on hand, they can't take it, and that's an untreated day. And so rather than getting them to think about the PDC greater than 80%, we said keep the number of untreated days less than 10 every 3 months of the year, and you win. And then finally, there was a detailed bit of information about each patient where we asked for a little bit of information and gave them a little bit more detail, and that was it. And so we ran this program from July through December of last year. We targeted almost 30,000 Medicare Advantage patients, which was the 10% of this plan most at risk who could make or break the star ratings for that plan for the year. And we attributed those 30,000 patients to 1,300 practices around the country who had prescribed those medicines for those patients. The bonus potential for each practice ranged from a few $100s if they just had 1 or 2 patients to over $50,000 per practice if they had a lot of these patients. And some of these were big practices with EMRs and all the trimmings and trappings to better manage their patients. Over a 6-week period, 570 of those practices, accounting for 2/3 of the members we wanted, onboarded, said yes to the program, signed conditions of participation, and began using it. We were astounded. I expected we'd get 10% of the practices. After I heard that top 10 list of problems with P4P programs, I didn't expect we'd get very many practices. But we had the ingredients right to at least get the practices engaged and thinking about the program. I have to say, this wasn't as simple as sending them a letter. As you can see here, there were more than 100 provider liaisons across the health plan that scattered into the field to literally show up in person or use the phone to accomplish the onboarding of these practices. And that's what helped achieve this goal of getting 2/3 of the eligible patients into the program. So how well did it work? For version 1.0 of a program like this, we were pretty happy. We were pleasantly surprised. But what I'm going to explain in a moment is that we've just scratched the surface of what this concept is capable of. So from 6 months, what I'm showing here is the adjusted difference in year-end adherence rates among committed versus non-committed practices, and then subgrouped by what type of commitment they made to the program. The first thing to describe is what this axis is that measures what these numbers are. This is the risk difference between committed and non-committed practices. Another way to think about it is it's the absolute increase in the adherence rate of the population. So 2.9 is a 3% lift, taking the population from 70 to 73% at a population level over the thousands of members that were included in the program. This is hard to accomplish. In relative terms, this looks much better. This is 10 or 15%. But this is an absolute lift. And what we saw was among our power users who were using the portal most often, there was a bigger lift than those who chose, for example, to just get the information by fax or other means. And so, as I said, pleasantly surprised, but certainly have some ideas for doing better, which I'll talk more about in just a minute. I want to also very humbly say there was a tactical error made in the implementation of this program, which is that when we launched it in July, we saw a big spike in activity on the part of these practices on this portal. And then in the fourth quarter of last year, we saw most practices never log in again. And that's because those 100 people who were the boots on the ground out talking to the practices were not active in the fourth quarter of the year. So I think we learned an important lesson here, which is the need for consistent engagement over the course of the program year. The other thing I just want to point out on this slide is that I've broken the results down by therapy area. And since this is a meeting focused on cardiometabolic conditions, I just want to point out that statins are where we saw the biggest increase in the adherence rate. Oral diabetes meds were the second leading category, And then the RASA antihypertensives were actually the hardest to see the improvement in. And so there does appear to be some difference in the elasticity of adherence across these three therapies. So this is the last slide, and I'm just going to kind of summarize what we make of this translational research project. And that's really what it was. We are building an airplane as we fly it. We are trying to do quality improvement at the same time we try to learn things, which is why this wasn't a big randomized controlled experiment. But here's what we think we've learned. Practices actually will accept gain-sharing accountability for medication adherence under the right circumstances. I think the biggest thing we learned is what those circumstances are. We also learned that these practices will use a variety of approaches for engaging these patients. Some will make phone calls. The doctor, him or herself, will make the calls. Some will use nurses. Some will use extenders and community health workers. It's important to leave them the flexibility to manage their patients as they see fit. The third thing was practices who committed to this program had a positive impact on adherence rates, which we were pleased about, but those who were the most engaged had double that impact on adherence. So the goal here is driving higher rates of practice engagement in order to see that maximum impact on adherence rates. And then the last thing is keeping these practices engaged is the primary barrier to greater effectiveness, and we think some of these elements of the program were also shown to contribute to that engagement that we did have. Timely and accurate data, participation from multiple payers would be ideal. The practices are asking for that now. Spectrum of options for sharing data may be necessary. Everybody doesn't have an EMR yet, and those who have it, many of them can't use it effectively for this kind of purpose. So we still have to send faxes to some practices. And we are also now hearing from the practices that benchmarking and feedback, how am I doing relative to the practice across town, can be a helpful motivator. And so we're adding that to the program this year. So let me stop there. I know I'm out of time, but look forward to the discussion, and let me thank you all for your attention.